Granulosis autoimmune thyroiditis. Again, Hashimoto thyroiditis is the most common cause of autoimmune, a leading cause of hypothyroidism. Parents often asymptomatic or hypertrophied, progressing to hypothyroidism. Early stage or transient hyperthyroidism possible with TSH, FT3, FT4 progresses to subclinical hypothyroidism, TSH, FT3 and FT4 normal, late stage over hypothyroidism, TSH with G3FT3 and 3FT4 antibody detection, anti-TPO antibody positive, anti-TG antibody positive, lipid profile, LDL, 3CL, CBC3AP, ACB, ultrasound to assess thyroid size, echo texture, and explore thyroid nodule, by needle aspiration to exclude malignancy or lymphoma, radioactive iodine update tests area 15 may be irregular. Hashimotosis, thyroid metabolism can have three phases: early stage, transient hyperthyroidism possible, low TSH, high T3T4 progression, so clinical hypothyroidism, high TSH, number T3 T4, late stage over hypothyroidism, high TSH, low T3 T4 antibody detection, anti-GPO antibody positive, 90% OHD. Anti-TG antibody positive lab test, high LDL, low HDL, low hemoglobin, ultrasound for assessing the thyroid size, echo texture, fine needle aspiration to exclude malignancy and lymphoma, radioactive iodine test if low assertion of technicians happen in transient hyperthyroidism, autoimmune thyroiditis, often referred to as Hashimoto thyroiditis, when illness to hypothyroidism is characterized by immune resistance attack on thyroid-linked inflammation and impaired thyroid function. The diagnosis involves a complete combination of clinical evaluation, laboratory tests, and sometimes imaging studies. Clinical evaluation symptoms may include fatigue, weight gain, cold intolerance, constipation, dry skin, hair loss, and menstrual irregularities. And some patients may initially present with symptoms of hyperthyroidism, genotoxic phase, followed by hypertrophied thyroid symptoms. Physical examination findings might include algorithm enlarged thyroid, which can be firm and nodular on per patient. However, the thyroid might also be atrophic and not powerful in later stage. Laboratory test thyroid stimulating hormone TSH elevated in hypothyroidism can be low or normal in early or late thyroid stages of the disease, and free thyroid toxin FT4 and 3-auto-zero FT3 decrease in hypothyroidism. FT3 might remain lower in early stage due to the preferential conversion of FT4 to T3 thyroid peroxidase antibody, TPO-AB, and thyroglobulin antibody TGAB. Presence of disease antibodies confirms the autoimmune nature of the thyroiditis. TPO-AB is particularly sensitive for Hashimoto thyroiditis. Thyroid-stimulating hormone receptor antibody TRAB primarily tested in Graves' disease only because the positive in some Hashimoto cases, especially those with thyroid-based imaging studies and ultrasound characteristics shows a hyper-heterogeneous echo texture of the thyroid gland. It is useful for evaluating the presence and size of a goiter and testing audio within the thyroid. The audio uptake tests generally not necessary for the diagnosis of Hashimoto, one may be performed to differentiate from other thyroid node disorders if the clinician curve picture is ambiguous. Typically, uptake is low in Hashimoto thyroiditis. Differential diagnosis, Graves' disease, another common autoimmune thyroiditis disorder, but typically present with hyperthyroidism, thyroid eye disease, and pre-TB or mixed edema are more specific to Graves'. So thyroiditis, they Corbian, usually presents with painful thyroid gland and transient hypothyroidism followed by hypothyroidism. Postpartum thyroiditis, it can present similarly to autoimmune thyroiditis, but typically occur in the first year after childbirth and may resolve spontaneously. Iron deficiency or excess can also lead to hypothyroidism or goiter. The next autoimmune antibody profile, points. The diagnosis of autoimmune thyroiditis is primarily based on the presence of characteristic clinical feature, elevated TSH with low FT4 and positive thyroid autoantibodies. especially TPO antibody. Thyroid ultrasound showing how heterogeneous pictures of the diagnosis, but it's not required for all patients. It's more important to differentiate Hashimoto thyroiditis from other causes of thyroid dysfunction. Thyroiditis is the management and prognosis can differ significantly. Patients with Hashimoto thyroiditis should be monitored for the development of hypothyroidism and other autoimmune disorders in SCR and increased risk. Okay, so let's know what we have. Read diagnosis of autoimmune thyroiditis. aka Hashimoto thyroiditis is the most common cause of autoimmune and leading cause of hypothyroidism. Patient often asymptomatic or hypertrophied progressing to hypothyroidism. Early stage transient hypothyroidism possible and progresses to subclinical hypothyroidism at a later stage over hypothyroidism antibody detection on TPO antibody positive on TG antibody positive and repeat profile LDL BCO CBC. Free HP, ultrasound shows thyroid size, equal texture, and exclude thyroid nodule by needle aspiration, radioactive iodine uptake test. With irregular Hashimoto disease, thyroid metabolism can have three phases: early stage transient hypothyroidism, possible low TSH, high T24 progression of clinical hypothyroidism, high TSH, lower T24, late stage over hypothyroidism, high TSH on lower T34 antibody detection, GTPO antibody positive 90% of HD. Anti-TJ antibody positive blood test evaluate LDL, low HDL, low hemoglobin, ultrasound for assessing the thyroid size, equal texture, fine needle aspiration to exclude malignancy and lymphoma. Reacting iodine objectives in low absorption or technician happening in transient hypothyroidism. Clinical evaluation symptoms may include fatigue, weight gain, cold intolerance, constipation, dry skin, hair loss, and menstrual irregularities, and some patients may initially present with symptoms of hyperthyroidism, thyroid toxide, base followed by hypothyroid symptoms. Specific examination finding might avoid whereas the thyroid can be firm and nodular on top patient. Hypothyroid might also be atrophic and a proper later stage. Whether the test TSH, FT4, FT3, TP, where thyroid considers antibody TPO, AME, thyroid stimulating hormone receptor antibody trap, and ultra trap, imaging study, ultrasound, and radio-iodine optic test generally not necessary for diagnosis of Hashimoto differential diagnosis, Graves' disease, and so thyroiditis, the core being present with painful thyroid gland and postpartum thyroiditis. Iodine deficiency exists high point. The diagnosis of autoimmune thyroiditis is primarily based on the presence of characteristic clinical features, elevated TSH with low FT4 and positive thyroid autoantibodies, especially TPO-AB. TPO-AB is TPO-AB, let's see, thyroid oxidase antibody and thyroglobulin antibody. TPO-AB, TGAB presence of these antibodies confirm the autoimmune nature. The thyroiditis, TPO-AB is particularly sensitive for Hashimoto thyroiditis, TPO-AB, TGAB. Okay, so positive thyroid antibodies is TPO-AB, thyroid ultrasound showing all heterogeneous equal textures of first diagnosis, but it's not required for all patients. It's important to differentiate Hashimoto's thyroiditis from the other causes of thyroid dysfunction. And thyroiditis, as the management and prognosis can differ significantly, patients have with Hashimoto thyroiditis should be monitored for the development of hypothyroidism and other autoimmune disorders. The SDR at increased risk.